It's okay. I think we're a couple of minutes early, so by my watch and by my clock, so don't worry about it.
Okay. So we're live on YouTube now, Chair, if you want to begin.
Okay, fine.
Thank you.
Welcome to the meeting of the Health Scrutiny panel. Thank you very much for those who turned up, especially to our visitors. And can I ask for any apologies for absence, please? I know that Councillor Halawi isn't here because she rang me, but Councillor Higgins has kindly stepped in to substitute for her. Are there any other absences, Chair? Sorry, Caroline.
Yes, sorry, Chair. We've got apologies from Councillor Hill. He's unable to attend today. Thanks, Chair.
Thank you. Go to item number 2. Any declarations of interest, please? I take it there are none. Thank you. And the minutes of the previous panel held on the 22nd of September. Can we approve them, please? Nobody going to approve them?
Move them, Chair.
Thank you. The minutes of the Health Scrutiny panel on 13th of October, they haven't been approved yet. So can I suggest that we defer it to the next meeting, please? Can someone back me on that?
Yes, Chair.
Thank you.
Good. Agreed, Chair.
Thank you. Item number 5, a COVID-19 update. And Mark, I think you're going to lead us on that, please.
Yeah, I think I'm starting off, and then Craig's going to. I'll warm you up, and then Craig will come in and be the main part of the agenda, I think. So I've really just got a kind of situational update of COVID, and then a little bit of detail of what we're planning over the next couple of weeks to be in the best shape we can be whenever the national lockdown ends. Could you share the presentation, Caroline, please? It's only 5 or 6 slides. It's not.
I'll start to share that now, Mark, if you bear with me.
Thank you. Sorry, Scott. There we go. Yeah, I can see that now. You want to go on to the first slide, please, Scott? There you go. So this is the rate of cases, rolling 7-day average rate per 100,000 for Middlesbrough tests. As you can see, it's a bit of an odd shape, really. And when we were coming down that peak, I've just marked up when we went into the level 2 restrictions when Hartlepool and Middlesbrough went in on the 3rd of October, and just under 3 weeks from those restrictions, we thought, all right, okay, the numbers are starting to come down, and then we started to see them uptick around about the 29th, 30th of October, and as you can see, they've continued on an upward trajectory that's a little bit steeper than the original trajectory. So I guess there's a couple of things that we can learn from that. One, we've still got high rates of infection in the community. 2, if that coming down in the graph from the 21st, 22nd of October is linked to the going to level 2, we've got 2 to 3 weeks before the lockdown measures start to take effect. So we might see our rates climbing a little bit higher. We've got 100+ inpatients in James Cook already, and there's a 3-week delay between people being a positive case in the community and potentially becoming an inpatient. Obviously, not all positive cases in the community become inpatient, but there is that lag time between positive being confirmed as a positive case and becoming an inpatient. So that's the picture, and the following a bit of a data dump today. Our rate at the moment, the 410, I think it is, per 100,000 is the highest that we've been from the previous peak of 407 per 100,000. So we're climbing back up to the previous peak. Could you move the slide on, please, Scott? So in terms of the sort of regional picture, you can see that Middlesbrough's testing rate, 2,825 per 100,000, is the highest in the region. So we're testing more people, which I think is a good thing. And we know that the access to testing in terms of the utilisation is that there is spare capacity for testing, so we don't think access to testing is an issue necessarily, although the rates of testing, the positives 13.6% is higher than we'd want. We would want it to be down at 5%, but as you can see, it's consistent with the positive rates in the rest of the North East, and Middlesbrough's been consistently in the top 5 really in the Northeast for the rate, and as you can see, it's that table is a little bit less up to date than the previous figures shared, because it's at 375 per 100,000 in the what's detailed as the current 7-day period. And you can see as well the Tees Valley authorities at the top of the table, with the exception of Gateshead and Sunderland. I think what we're seeing in the Northeast 7 that went into Tier 2 restrictions earlier than we did, they went in on September the 18th, I think, their numbers dropped off, plateaued, and are starting to go back up again now, a little bit like ours are, which is why you're seeing Sunderland and Gateshead come back up that table in terms of their infection rates. Next slide, please, Scott. Just in terms of the age group, so this is age bands per 100,000, so that the kind of relative rates of age bands. And I think the interesting thing from this picture, the black line is the overall picture, which matches the first slide that I showed. But in effect, working age adults, excepting 15-year-olds aren't working age, but between 15 to 34 up to 50 to 64, those 3 bands at the top are pretty much clustered together between 400 and 500 cases per 100,000. And then you've got a gap, and then you've got the over 65 at around about 200,000 cases per 100,000, and then the school-age children, excepting it goes beyond 14, but 0 to 14, around about 100 per 100,000. So the 65 plus is largely driven by regular care home testing, but in effect, if with the exception of underlying conditions, the over 65s are the more vulnerable in the population. So 200 cases per 100,000 is still too high, but it's good to see the split between, in effect, working age higher and the more vulnerable 65 plus a little bit lower than that. And a lot of those tested positive in care homes are asymptomatic at the moment. Whether that will change as the disease progresses, we don't really know at this stage. Next slide, please.
Mark, can I just ask you something on that before we move on, please? Am I right in thinking that the age group that appear to be more, what's the word, inclined to contract this virus, they're the people that are out and about more?
I think what we saw, if you look sort of a quarter back, where the yellow line, which is 35 to 49, that peak there, I think where previously we saw perhaps a younger age range. So right in the middle of the graph, you can see the 15 to 30. The 15 to 34 age peaking up towards 500. I'm pointing at the screen. I don't really know why. And it was a younger age group to start off with. Now, I think you're seeing it's all ages between 15 and 64 are pretty much at the same rate of positive cases. And I think that's probably reflective of the fact that most of the spread, once it's got into a household, is within the household. So it sort of reflects the demographics of households as much as anything else. I know older people live in households than just 64, but I think that's the sort of key route for the spread of it is within households.
But it's not affecting children.
No, and that might be either because they're less likely to get tested because they may well be asymptomatic. I don't think it's necessarily the case that children are more likely to be asymptomatic, but it could well be about likelihood of them getting tested as much as anything else.
I see.
I mean, we are seeing children testing positive in schools, but not at big figures, and it pretty much reflects the rates in the community. Schools have done a great job in preventing kind of infection spread within the school environment. So I think that's consistent with the national picture. Actually, the 0 to 14 positive tests are low, and quite what that means we've yet to really work out. But it's useful. I think there's a clear consensus emerging that age group aren't particular spreaders of COVID in the way that they are spreaders of flu. I
wasn't aware children were being tested in schools.
No, sorry. Well, they've been tested in the usual testing places, but we get them reported through the schools.
I see. Thank you.
Okay, next
Yes.
slide, please, Scott. This is the last slide, and really, I wanted to highlight a couple of things. Really, this has got everything of our approach in on one slide, really, which is why it's a bit busy. But the sort of model that we're looking to deploy is the four bubbles there. So building our community capacity, because we can't really enforce our way out of this. We can only really get out of this with the consent support of our communities. Changing test and trace to a more local model, which I'll go into shortly, protecting vulnerable people, and we've talked about those over 65 and those in care homes, and ensuring that those settings that are open still, either workplaces or places that people can still visit, are as safe as possible. And there are key areas of activity and have been for some time, but this is the model that we're trying to build to make sure that we can protect our communities as much as possible. And then looking at the sort of purple boxes around the outside, I won't go into all of those areas, but the ones that are shaded slightly darker are the ones that we're working on across the northeast, the 12 authorities in the northeast. So the first one is the mass testing, and people will have heard Matt Hancock on the news this morning talking about mass testing. So this is the lateral flow test, which return a result within 20 minutes to half an hour, and we will be getting quite a large supply of those tests. And what we're looking to do is use those to protect vulnerable people as much as possible in three areas. Firstly, testing. Opening up testing to, and this is plans, this isn't in place yet, opening up testing to care home visitors, potentially designated visitors. So a resident would have one member of the family who could visit them that will get tested on a regular basis. Two, staff that visit vulnerable people in non-care home settings, so domiciliary care staff and other staff. So basically rolling out the kind of approach in care homes to vulnerable people that aren't in a care home. And thirdly, looking to see whether or not we can test care home staff better through this route, because they get their result obviously more quickly, and potentially we could test more frequently than weekly to further protect those vulnerable people in care homes. So that's the approach that we're looking to do across the northeast, because obviously the care homes operate in more than one borough, and having some consistency on that level will be really helpful. And we haven't worked through the numbers yet in terms of the numbers of tests that we're anticipated to get. I think it's a weekly amount of 10% of the population. So other than the immediate question of where on earth do we store all these tests, there's a significant number of tests that we can use to understand better what's happening in our local communities, and we'll target them at the vulnerable people as described in the outbreak management plan that we published in June. So that's the first thing to highlight. The second thing in the test and trace really is we're looking to develop our locally enhanced contact tracing. So people will be aware that the national programme reaches, I think it's around about 75% of cases, so positive cases. There's 25% they don't reach, and less than that for contacts of cases. So what the locally enhanced programme does is after, I think it's about 8 hours of the national team trying to contact people, they hand them over to the local teams, and we're building a local team that will be able to contact either cases or contacts of cases. Whereby our contact will be, first of all, from a local number, which hopefully will mean it's more likely to be responded to. And secondly, we can actually detail the offer that's available to people, and we'll have that local knowledge of what's around and understanding of people's circumstances. So we can connect them into financial support, we can connect them into support through the VCS, and we can connect them into any other sort of support packages that are available to help them to isolate. So it becomes a much more supportive conversation than just informing somebody that they're a contact. And we've been doing that in terms of contacting cases for the past couple of months. So we've got a good approach to that, and we know what we're doing with that. It's just the resources to enable us to do it, which we're using the Test and Trace grant and other grants to do that. However, that is an interim measure, because there's a move to try to develop a northeast-wide test, trace and isolate programme that I suppose starts from the perspective that the national system has, marginally improving the national system isn't good enough in itself, because it still has delays in turnarounds from tests to results. people can be called 30, 40, 50 times. We've spoken to people that have been called that often. So by the time we get hold of them, they're bored of being contacted all that time and cynical of the whole process. So we're working, led by Eugene Milne, who's the DPH for Newcastle, pulling the resources from the national system to redevelop a local model that hopefully removes all of those inconsistencies and problems. The national system didn't even pick up the hundreds of people that had tested positive at Newcastle University, so their kind of situational awareness is very poor as well. So we're looking to develop this locally enhanced contact tracing, which will improve the national model, but also at the same time, which obviously has a lead time to it, get the resources from the national program with it to the northeast and completely overhaul and redesign the program so it works a lot better. So they're the mass testing and the contact tracing and the redesign of the program are the fundamentally different things that we're looking to do. And then just to pick up one other thing, the COVID vaccine program will be developed on a northeast basis. I don't have any further insight on the announcement yesterday around the vaccine, other than I think I think in terms of religious holidays, my guess would be it's more likely to be Easter than Christmas when it gets rolled out, and we need to develop our plans presuming that sort of timescale rather than thinking that there's a solution and an answer around the corner. We need to work on plans to protect our communities throughout that program rather than thinking the vaccine's going to be here in the next couple of weeks. I'll pause there, Chair, because I could take forever talking through that approach, and I know Craig's got quite a big presentation, so I'm quite happy to take either questions now or wait till Craig's finished his presentation.
I have just two. I don't know about the rest of the panel. I'll ask them in a moment. My first one is, can you explain what you mean by the lateral flow test, please?
Yeah, so the existing test is called a PCR test, and I can't remember what PCR stands for because I'm terrible at remembering acronyms. But that is a different test and involve. Somebody's telling me what it's called, but I can't.
It's a polymerase.
Janet is trying to tell me what it's. Polymerase chain. What does the R stand for? Test. Reaction. Thank you. So thank you, Janet. The PCR test basically involves a swab down the throat and up the nose, and make sure you do it in that order. And then that gets sent away to a lab. The lateral flow test is more similar to a pregnancy test in that the either a saliva test or the same swab or similar swabbing approach is returns a result within 20 minutes through the kind of standalone kit in itself. So there's no lab involved, which obviously takes out the delay of samples being sent to the lab, being tested in a lab and being returned. So you get your result in 20 minutes. The issue that we've got to confirm yet is how they link into the test and trace system, which apparently they do, but I haven't seen how that works yet. But that's okay. Some of the details we've got to understand.
Okay, thanks. The second one is you touched on let me see, the number of people. I think you said that was 100. The number of people actually in our hospital here that confirmed. Can you remind me of the figure, please? Was it?
I think it's
the first slide.
Yeah, it's over. I think it's about 120. I'll have to check when Craig's talking. Okay, I'll check and I'll update. Fine. And about 14 in critical care, I think. That's
fine. Then you said that there were a number of people who had been diagnosed, but wasn't sure whether they were going to be admitted to hospital. Have you an approximate figure for that, please? No, so that we can estimate how many may end up.
Yeah, there are some models around that. I don't have the sort of conversion rate from if 100 people are tested positive in the community, you could expect 3 of them to be admitted as an inpatient. Those models do exist. I don't have those figures to hand.
That's fine. That's fine. Does anyone else have any questions?
Yes, Chair. Councillor Rooney has a question.
I think Councillor Coop had his name up first, and then Councillor Rooney, please.
No, ladies first. Councillor Rooney, please.
Okay, Denise, off you go.
Thank you. It's going back to the what you said, Mark, there about the North East programme. One of the issues regarding payments for individuals is they won't be able to access it unless they are told by the NHS to isolate. Is that being taken into account so that if anybody needs to trigger something to receive a payment in order to stay off work, that's factored in and and is available to them.
Yeah, it would be to all intents and purposes the same program from that perspective, but it would just be operated in a different way. So at the moment we can advise somebody. We've had people that have been told to isolate but don't have proof for various different reasons, that we've been able to get the what's called the CTAS number for them, so they're able to claim the financial support to isolate. So that would be factored in part of that. In fact, on the diagram we've actually looking to increase the financial support, the kind of discretionary element of that, because having run the scheme for 2 to 3 weeks, it found that there are people who don't meet the criteria, but actually without that support wouldn't be able to isolate. So the critical thing is that people are able to isolate to prevent further spread.
Thank you.
Councillor Coop?
Yes, thank you, Chair. Just looking at the figures there, I noticed yesterday's 108. You have the actual figure for today, the actual infection figure. I know that's 410 by 100k, but do you have an actual figure for today? I know yesterday was exceptionally high.
We don't tend to do it because there's a bit of a delay in getting the results. We tend to report 2 days prior to today, and the numbers will continue to change for the, so for example, the specimen dates that we updated today were between the 2nd of November and the 8th of November. So there's the graphs always have this sort of dip at the end where it looks like things are improving, but actually it's to do with the delay in getting the test results back. So that's why we report back a few days.
Councillor Hubbard, did you waive or did you want to speak?
I understand. So do you actually have the figure for today out of interest, or haven't you got that yet?
I could get it for you. I don't
It's
have it.
okay.
I
was just very concerned that we're going from 65 to 70 to 80 to 90. Now it's hit 100,000. Just one quick question on that. Do you, having been in last week to one of the big shopping centres, I noticed that even inside people were wearing masks. Do you think the problem could be that people are going to there, getting the virus and going spreading it around the home? Because I was very perturbed. There was no signs up at all saying you wear a mask in a shopping mall. Everybody knows should do it. Is that possibly
well, it will have an effect. All of these things are about marginal gains, aren't they? That there's no silver bullet to this. So the more people that wear masks, the less spread of infection there will be. But it doesn't mean there'll be zero spread of infection when people are wearing masks. But it's a good thing that people wear masks, and obviously the more that we can promote that, which we have been doing right from the start of this, including sending masks out to all households in the borough. So it's part of building that sort of community prevention approach.
Are you finished, Councillor Coop? Okay. Councillor Hubbard, did you want to speak, or were you just sort of waving?
I was just waving to you, Chair.
Oh, okay. That's nice. Okay, if there are no more questions, I think now, Craig wants to come in.
You ready for me to present now, Chair? Yep. Okay, so what I was hoping to do is just talk you through what the health response has been to date in terms of where we are with COVID-19, and then Dr. Janet Walker is going to provide an update on where we are with the COVID virtual ward. Unfortunately, my slides aren't as visually stimulating as Mark's, but they do just cover some of the key facts in terms of where we are in the response that's been put in place. So if we could move on to the next slide, please, Scott, that'd be great. Okay, so just a bit of context where we started from this year. Clearly, as an NHS, we had lots of plans around the things that we wanted to do this year. The NHS at the national level produced the operational planning guidance and the long-term plan, which local commissioners, CCGs, were asked to respond to. That was published back in January this year. Before we got the opportunity to start to develop our response to that, we started to enter into the pandemic, the COVID-19 pandemic, which meant that on the 30th of January, the NHS declared a level 4 national incident, and we moved into what was referred to as phase 1. So that was preparing for our pandemic response. Then we've subsequently moved through a number of other phases as the pandemic has hit. We've seen the first wave, and then as we came out of that first wave, what we started to recall phase 3 and recovery of services. Obviously now we're starting to move into yet another wave, wave 2 of the pandemic, and our responses continue to evolve. This presentation has been shared a couple of weeks ago with Redcar Borough Council's Health Scrutiny Committee as well. And what I'll try and do is bring you up to speed with what's happened since the presentation was first delivered to where we are now. So if we can move on to the next slide, Scott. In terms of phase 3 and coming out of the first wave and looking to try and restore services, there was a number of priorities that the NHS was given as a whole that local commissioners had to work through with our providers, so with the hospital trusts, with our community providers and our GPs. And there were a number of priorities identified. Are you okay with that?
For me,
Yeah, sorry, I thought
I was just coughing. I was coughing.
Sorry, apologies, Chair. So yeah, the 3 priorities were around returning to near normal levels of pre-COVID health services. So that was things like elective surgeries, outpatient appointments, cancer treatments, making sure that mental health, LD and autism services were up and running back to their usual state. Preparing for winter and the winter demands that we expect to see, as well as preparing for further or future spikes in COVID waves. And then in doing all of those, being mindful of any of the innovations or lessons that we learned through the first wave of the pandemic and looking to lock in those benefits, but also thinking about protecting our staff and making sure that we've got systems, processes and services in place to support the health, well-being and continued recovery of our staff as we move forward. So if you could flick onto the next slide, Scott. What I've tried to do is just to give a little bit of a feel for some of the specific actions that we've taken and where we find ourselves in terms of responding to those asks. So in relation to cancer, 2-week wait referrals were maintained throughout the pandemic. So at no point did we stop asking GPs to make 2-week wait referrals or seeing and managing those patients in a hospital setting. But obviously we had to do that with a close eye on the infection prevention and control measures that needed to be undertaken, making sure that our staff and our patients were kept safe whilst they were being seen. We did see a significant reduction in the number of referrals that came in to the system and the amount of activity we were able to undertake, so that's outpatient appointments and treatments during the first wave. However, since May, we've seen a return to near normal levels, not quite as high as we'd have expected, but an increase towards near normal levels over the summer period. In terms of elective care, so this is routine surgeries, hip and knee replacements, and other such procedures. We've been looking to work with the hospitals to make sure that advice and guidance is provided to GPs and other referrers to make sure that any referrals that are made are appropriate and that only patients who really do need to be seen in a hospital setting are seen. That any patients who've got long waits, and we term long waits at the moment as anybody who's waited 52 weeks or more, undergo a harm review. So to make sure that no harm has been caused and no further harm can be caused as they wait, so that we absolutely understand what the needs of individuals are and how clinically urgent their treatment is. We've looked to make the best use of all of the estates that we have. So you'll be familiar with the fact that we've got access to the James Cook Hospital, Redcar Primary Care Hospital, where there are theatres, the Friarage Hospital, and we've been working with James Cook Hospital as a whole to make sure that where possible, they're making the best use of all of those facilities, and that where possible, we're looking to offer our patients access to those sites so that we can reduce waiting times as far as possible, or maintain waits where they are as far as possible. Now, in addition to that, we're quite fortunate in the Tees area. We've got access to a number of independent sector hospitals. So you might know some of those as Ramsey Hospital in Acklam or the Nuffield over in Stockton. And what we've been able to do is work with those hospitals to continue to provide routine planned elective care. So NHS treatments taking place within those facilities. The reason we've been able to do that is because these facilities don't manage COVID patients. They don't manage urgent or emergency cases like James Cook would. So what that's meant is we've been able to operate them as almost COVID secure facilities and just put elective programs through there. So lots of orthopedic work, lots of gastro work, lots of cancer treatments have been able to flow through those hospitals and keep those most urgent patients flowing through the system and making sure that they're seen in the most timely fashion that we can at this point in time. In terms of primary care and community services, we've ensured that 100% of our GP practices right across the Tees Valley have initiated online and video consultation and triage. So everybody should still be able to speak to or make contact with a GP. And we've also looked to make sure that they're all continuing to offer face-to-face appointments where they are absolutely necessary and appropriate. But clearly, where we are at the moment, for the vast majority of patients, it's safer and more effective to offer video or telephone consultations. We've continued to provide community services, so district nursing support's been in place right throughout the pandemic, and we have restored other community services that were temporarily stood down during the first wave. We've also piloted the COVID virtual ward approach, which Janet's going to talk about shortly, which has now been taken up as a national offer and will be rolled out right across the country. If we could move on to the next slide, Scott. Brilliant, thank you. In terms of mental health and learning disability services and retaining those to as near normal as possible, the Tees IAP service is fully operational, so IAP services are out there. We are anticipating that there will be a significant impact on the mental health of the local population as we come out the other side of COVID, and it's absolutely key that our mental health services are there and ready and able to take patients and provide the support required. So IAP is fully operational and should be accessible for all of our patients and residents.
Sorry, Craig, can I just ask you a question? A lot of people, this is being live streamed. A lot of people want to understand what IAPT means.
Sorry,
so could you explain, please?
Yeah, absolutely. So IAPT is talking therapies. So lower level mental health support for individuals that need it, which can be delivered over the phone or via this type of setting as well. Is that okay?
Thank you. Yes, thank you.
Thanks, Chair. Okay, so in terms of 24/7 crisis helplines, we have a single 24/7 helpline in place, single point of access, which will then help divert individuals who are in need to either adult or children's crisis teams, making access to those services as easy, streamlined as possible. And also during the first wave of the pandemic, our practices continued to work with and support those groups that needed additional support, like those with learning disabilities, in order to make sure that they could continue to access annual health checks and various screening programs. A further ask during phase 3 was around preparing for our winter surge and the future COVID spikes that we anticipated to see, which we're actually working through now. So we continue to work in partnership with the local outbreak groups, with Mark and colleagues from the health protection team through the health protection board, to make sure that any necessary arrangements were put in place and health was able to support in terms of anything that we needed to do in response to further outbreaks or additional guidance. We've continued to support all of our providers, all of the hospital trusts, all of our GPs to follow the latest infection prevention and control guidance, making sure that patients and staff are kept as safe as possible. And we've continued to follow all Public Health England and Department of Health and Social Care policies on testing and the frequency of testing. So you might be familiar with some of the most recent guidance around testing those individuals that are visiting care homes. So that's something that we've been working through with Mark and his team and with our local providers to make sure that we can keep our care home residents and staff as safe as possible. In terms of specific preparations for winter, we've got the flu vaccination board up and running, and we're working to roll out the flu programme, which is currently happening across the Tees Valley and the broader northeastern Cumbria. We've launched a new initiative called Talk Before You Walk, which is helping support individuals with urgent care needs, hopefully reducing the amount of traffic into A&E departments that isn't necessary. So if patients have got needs that can be better managed away from A&E, then Talk Before You Walk and the 111 service will be able to advise them and hopefully help keep people and our staff safe and away from those places where perhaps they could come into contact with other individuals that may have COVID. We've also put some special arrangements in place for this winter to help all of the different agencies across health and social care work together in a more joined up way so that we can respond to any pressures that we do experience, whether they're winter pressures or COVID related. And that's something that went live this week on Monday. Okay, Scott, if we could click forward again. Thank you. In terms of learning lessons from the first wave of the pandemic, I think there's some key lessons that we've learned around workforce, and we've implemented a range of initiatives to support staff and staff wellbeing, not only within the CCG, but across our providers as well, to ensure that our staff are looked after, that they've got the right emotional and mental health support that they need, so we can keep them fit and ready to go for the next wave of whatever might come. The CCG itself is committed to implementing agile working, and in turn we've supported our providers to do that as well. So where possible, if people can work from home, we've supported that. We've got lots of people working remotely. We've got clinicians who are working remotely and supporting patient interactions through video conferencing and telephone appointments, etc. And that's been a really positive development that's helped keep the health service going over the last 6 or 7 months. And that's something that we'll look to continue to do over the winter period, while we expect increased pressures not only from winter but also wave 2 of the pandemic. In terms of health inequalities and prevention, we've looked to maximise opportunities for clinical triage, which has really helped ensure that we get the right patients into services as quickly as possible, and those who don't need to be seen face to face or attend a physical service don't have to. I think that's got some real benefits and something that we'd want to hold on to as we move forward and come out the other side of the COVID pandemic. We've targeted support for those with long-term conditions, so individuals that we know are vulnerable or need additional support. We've looked at putting additional support around them. Examples might include things like respiratory advisory service for individuals who are known to have respiratory conditions that might need a little bit more support at the moment to manage their condition, but also the service that Janet's about to talk to shortly as well. And the CCG's work with the Learning Disability Network to develop a toolkit for delivering annual health checks and flu vaccinations during COVID-19 for those individuals that do have learning disabilities and need a little bit more support. Okay, Scott, if you could move on to the next slide for me. Thank you. A few other developments. We've tried to establish some joint planning groups across health and social care to make sure that we've joined up our approaches and that we're providing the right support not only to our vulnerable groups but to our whole population. And that group meets twice weekly. Mark's kind enough to join from a public health perspective and keeps us up to date with the latest guidance and steps that we need to take from a public health perspective. We've implemented a number of new ways of working right across the health and social care system, specifically in health, advice and guidance, virtual appointments, the COVID virtual ward again, which Janet's going to pick up on. And we're also looking at revising some of the plans that we had originally set for the beginning of this year that we'd hope to implement through the year to improve services, and not only the quality of services but access to services across the Tees Valley, in light of the fact that we've lost a significant proportion of the year dealing with the pandemic. So we'll be looking to continue to engage with social care partners, providers and the public around what are our priorities for the coming year, and how do we, if you like, catch up for some of the things that we've not been able to do whilst as a system we've collectively responded to the pandemic. So if you can move on again, Scott. Only a couple of slides left from me and I'll hand over to Janet. We've clearly moved on now from looking to recover from the first wave to starting to experience the impact of wave 2. And we're very much in the stage of developing our responses to that. It's a little bit different this time because not only do we have the impact of COVID to try and manage, but we've also got winter or seasonal pressures coming on as well. So we often see a lot of additional respiratory conditions and ailments come to the fore during winter, and we see increased demand for hospital beds, non-elective admissions, etc. And all of that now needs to be managed in an environment whereby COVID is still prevalent, and we need to take special arrangements to make sure that we've got enough hospital capacity for COVID patients, but also those who need emergency care that aren't suffering from COVID as well, whilst trying to do the catch up from the summer of the elective programs and seeing those patients who've been waiting to be seen longer than we would have otherwise expected. So it's quite a complex process that we're working through. We're trying to make sure that we've got enough services, bed capacity and staff to meet all three of those requirements. But it's a difficult balancing act at the moment, and we need to be realistic in our expectations around what we can achieve over the winter period. And it may be that at a point in time, we do need to think about slowing down on the elective work that we can do, so the routine hips and knees, whilst we concentrate more on the urgent need of those patients who are suffering from seasonal ailments, but also those coming in with the resurgence of COVID as the wave 2 starts to take full effect. And I think, picking up on some of Mark's slides from earlier on, what we have picked up through the close working that we've been undertaking with Mark and his team is that usually about 3 weeks after a peak in community cases, we see that peak materialise as additional hospital admissions and pressures on hospital beds. So what we've been looking to do is join up all of our intelligence, information and resources so we can start to plan when we've seen a peak in the community. How do we respond to that in terms of ensuring we've got the right capacity available in a hospital setting, and that we're supporting those patients who no longer need to be in hospital to return back to their usual place of residence, whether that's their own home, a care home or another setting. If you could move on again for me, Scott. Brilliant. So a couple of critical themes or key lines of inquiry as we refer to them in terms of planning and helping navigate through this second wave of COVID. Key priority is putting patients first, so making sure that we maintain the quality of care, that we have safe services in place, robust governance, that we're linked up with our colleagues in social care, and that we maintain the highest possible standards of infection prevention and control, so that we're not spreading the virus within our patient groups and across our staff. Caring for our staff, so looking after the workforce, making sure that their well-being is one of our top priorities. Staff are the backbone of the NHS. Without our staff, we can't deliver any services, so we need to make sure that they're fit, well and ready to go. Trying to manage demand, so again linking to the winter pressures and urgent emergency care, making best use of some of our services that we've got out there, things like Talk Before You Walk and 111, to make sure that patients are accessing the right service at the right time, and that we're not inadvertently putting additional pressure on the hospitals through things like inappropriate A&E attendances and inappropriate admissions. Making sure that we've got sufficient support for critical care and ITU. And at the moment, we're looking at how we can further expand our critical care capacity within South Tees Hospital Trust. And they've been undertaking work this week to look at opportunities to expand critical care into some of the elective programme, and restricts the amount of routine operations that they can do. But at this stage, it's a case of prioritising where do we put our energies, where do we put our resources to best support the population. Some of the critical functions that we're concentrating on and trying to ensure that we can keep operating as normally as possible. Primary care, making sure that primary care is there, accessible, but also ready to support in terms of vaccination plans, not only around influenza, but also around COVID-19. Making sure that we support with testing. The testing capability is key to making sure that we've got good flow within the acute hospitals, so that we haven't got patients inappropriately waiting in a hospital bed for a negative test so that they can move on to their usual place of residence, and also making sure that we can move patients out of A&E as quickly as possible once we know what kind of pathway they need to be on. Are they a COVID positive patient or are they not a COVID patient? Working with pharmacies to make sure that we can keep pharmacies running, but having half an eye on what's happening with Brexit, EU exit, to make sure that we know where we are and that we've got relevant supplies and stocks in place. And also thinking about recovery and continue to think about how do we restore services. So before we even plan to make any changes to services or step down parts of the elective programme, we're already thinking about how would we restart them, what would that look like, what would the interdependencies be around having staff, bed capacity, facilities available, and how can we use our local independent sector more wisely? We talked about that earlier on, but how do we use it more wisely to keep the elective programme running right through the winter period wherever possible? And then the final things around resilience and making sure that we've got digital resilience out there, so we've got systems and processes in place so staff can work in new and different ways, that we've got cyber preparedness so we know how to operate in very difficult and extreme circumstances, and making sure that our business continuity plans and contingencies are all in place so that should the worst things happen, we've got the ability to keep the NHS running and make sure that those critical services that absolutely need to be provided can be provided. And I think that's pretty much it from me, Chair. Dr. Walker's now got a brief presentation to deliver on the COVID virtual ward. So I wasn't sure whether you want to pause there or I can take any questions.
Yes, I do. I do, Chair. Before I open it up to questions, can I just make a couple of points, please? I don't know about other councils, but I have found on social media an increasing number of people who are accusing the NHS of more or less abandoning other patients and with preference to COVID patients. Even people saying, my brother, my uncle needed cancer treatment and he was turned away. And obviously, from what you've told us, that isn't happening. If people do need treatment, they are getting it one way or another. And secondly, I'm glad that you touched on staff morale, because I think it's vital that it's kept up. Staff morale needs to be kept up at any time, because let's face it, we all know how can I explain it? A traumatic job, nursing and working in a hospital as such can be. But at the moment, it must be absolutely horrendous. I know a couple of people who do work in hospitals and they're coming home absolutely drained because of what they've had to do, what they've seen, etc., etc. So yes, I'm glad that that came up. So I'd just like to open it up to questions from the rest of the panel, please, if they have any.
Just in terms of your first point there, Chair, clinical prioritisation of all patients is taking place, and I would like to hope that the NHS hasn't turned its back on any patient, but clearly we need to prioritise those who have the greatest level of need to be seen first. And it may be that some individuals are waiting longer than they otherwise would, and longer than we would like them to wait. But clearly, with the circumstances that we're operating under at the moment, the reduced available, it can't be avoided. Yes.
Yep. Thank you, Chair. Does anyone have any questions before we move on to Janet, please?
I have a question, Chair.
Okay, Councillor Cope, off you go.
Yes, thank you. Can I just say, I know that the One Life Centre, the X-ray department, which I had to use a couple of weeks ago, have been working as normal. They've been working just as hard as they always do. So I think people like that need congratulating. So just to say that the health service shut down is just totally not true. Can I just ask about the flu vaccination programme? There were reports earlier on in September, early October, that the people were running out of jabs and various other problems. Has this been resolved? Has everybody that needs to get the flu jab up to now been offered it?
Yeah, if I can answer that, if that's okay. Chair, is that okay? I'm probably best placed.
Yes, of course, yes.
I'm delighted to say that we have managed to obtain nationally additional supplies of flu vaccination. The uptake for vaccinations this year has been unprecedented. And yes, many people came forward right at the outset of the programmes. And actually, yes, it is true, demand did outstrip supply. However, the Department of Health and Social Care has got additional stocks that have been coming online through November and will continue to be released to practices that require additional stocks through November, and then potentially into December as well, as we look to the feasibility of vaccinating those individuals aged between 50 and 64 that wouldn't previously have had a flu vaccination. So yes, practices, GP practices and community pharmacies are receiving additional stocks throughout November into December to make sure that those that are eligible for the vaccine and want to take up the offer are able to get that. There are many different groups that were added into the flu campaign this year, recognising the additional sort of demands on winter pressures and with COVID. So there's new groups that can have it this year that haven't been able to have it previously, but with the additional stocks, we can now respond to that demand.
Excellent, thank you. I know I got my flu jab fairly early, so I was quite pleased about that. But I was just concerned because there were talk about that. So if you're going to do that, do we have any idea about the amount of flu in there? Because it doesn't seem to be very high at the moment. That could well be down to the excellent program you've got to inoculate people against it.
Yeah. If I'm allowed, Chair, if that's okay, the national level of flu from the flu surveys that looks at whether flu is circulating or not has it about 1.2 to 1.4 case per 100,000 population, and that is significantly under the threshold of 12.2 per 100,000 of population that is required to declare that influenza is circulating. So at the moment we are definitely out of flu season. We have not got into flu season yet, and hopefully long may that continue.
Thank you,
Absolutely.
Janet.
Thank you.
Any further questions?
No, thank you, Chair.
No. Well, would you like to carry on then, Janet, please?
Thank you very much, Chair. If you can go to the next slide, please, Scott, if that's okay. Thank you. I know some of you have had a little bit of information previously about what is a COVID virtual ward. And I think last time we referred to it as COVID care at home because it seemed to sort of sum up a little bit better what we were talking about. And it's basically a service that recognises that for many patients who are COVID positive, they do not need to be in hospital, but we need to be monitoring them potentially at home. And the little picture on the screen is a pulse oximeter that measures the patient's pulse rate and oxygen rate. And clinically speaking, obviously with the appearance of COVID, we learned a lot about it very quickly. And we learned that often respiratory viruses, you get exceptionally short of breath, and clearly you're working very hard with your breathing. But with COVID, that wasn't always the case. And patients could actually be really quite poorly and not realise how poorly they were. And it's something called silent hypoxia, which is when the oxygen circulating in their blood was much lower than it should be, but yet you wouldn't necessarily tell by looking at them how poorly they were. So clinically, it felt like a bit of a no-brainer, really, that monitoring these patients with a simple piece of kit that just goes on your finger, doesn't involve any blood taking, could actually help us to detect those patients that possibly were deteriorating that we hadn't realised on clinically with how they presented. If you can go to the next slide, Scott, if that's okay, please.
Janet, can I just ask you something, please, on that? When you say it measures the oxygen level, is that the oxygen level in the bloodstream or the oxygen that they're taking in with each breath?
It measures the oxygen in the bloodstream. The little finger probe goes on your finger, and it measures the oxygen in your blood cells. And it's ever so clever, but it's useful. Now you would expect that hopefully you're 100% oxygen saturation or 99%. Not everybody runs at that level, but this little machine picks up minute changes in the oxygen in the blood. And if we can go on to the next slide, Scott. The reason this is important is because we learned quite quickly that when your oxygen saturation was lower, and once it's lower, you have, unfortunately, a much higher mortality from COVID. So if you are using this way of monitoring patients at home, if you pick up any deterioration in their oxygen saturation more quickly and get them into hospital for an assessment and potential treatment in hospital, their outcomes are likely to be better. So the virtual ward, we became a pilot in July, and as a way of making sure that we could intervene earlier to try and reduce the mortality and hopefully make it such that patients had to stay for a short time in hospital and hopefully reduce the complications that can occur as a result of COVID. If you can go on to the next slide, please, Scott, if that's okay. Thank you.
Janet, sorry, can I ask you something? Can we buy those? Can we buy that?
You can indeed buy them, and there have been some schools of thought nationally that actually in your first aid kit, you should have a thermometer and a pulse oxygen saturation meter. Now, understandably, whilst they may not be very expensive, they are far too expensive for some of our population to be able to afford to have, and they don't last forever. However, as part of the pilot, part of being accepted as the pilot, we did receive a supply of pulse oxygen saturation meters, and yes, as part of the pilot, we do, after someone's used them, we do get them back from them so we can reuse them after stringent infection prevention control measures to clean them. But yeah, they are used. You can buy them yourself, and it is true that the ones that you can purchase are as accurate as the ones that we will use in the main. But if patients are accepted onto our monitoring at home, we provide them with an oxygen saturation monitor.
Thank you.
Recognising that as we've been part of the pilot from July, that we offered a service 7 days a week when the ward was run by Alliance of the three GP federations across the Tees Valley. that accepted patients onto the ward for a period of monitoring for up to 14 days. And the outcomes were good. Patients really valued the monitoring, and we know that we managed to recognise deterioration earlier and got patients into hospital that needed to sooner, and reassured many patients that actually, no, they were doing okay, and that reassurance was obviously really valued by patients. So recognising some of these outcomes, nationally it was agreed that the pilot scheme should be rolled out across the country. And it is an expectation that by the end of November, all areas in England will have access to some form of pulse oximetry monitoring for COVID positive patients in their own home. If you can move on to the next slide, if that's okay, please, Scott. Thank you. When we started out our pilot, as some of you may remember, our pilot was very broad because at the time in the summer, the numbers of patients with COVID were very low, which was great, obviously, but there were some outbreaks. But understandably, with emerging into the second wave, we know that the rates of COVID positive patients are significantly rising. So with that, in conjunction with the evidence that has been gained from the pilot site as to who actually gets greatest benefit from the monitoring, the criteria for admission to the virtual ward, or what is shortly due to be named nationally as the national scheme starts at the end of November, COVID oximetry at home, which I'm so sorry doesn't trip off the tongue, I don't think, any easier. And our COVID care at home, we still caught it better, but it is what it is. We know that we have to change our criteria to make sure that we are monitoring those patients that we know get the greatest benefit from that monitoring. So our criteria currently is that to be considered for admission to the ward, if you're over 65 years old and you have COVID positive on swab, or we know from a hospital inpatient stay that we know you have COVID because of other signs on your x-rays or other tests, then you are eligible. If you are under 65 years old and have a learning disability, you are also automatically eligible for admission to the virtual ward. Patients who are on the extremely clinically vulnerable list are also automatically eligible for the ward, even when they are under 65 years old. Now, we know in our area, sadly, that there are some patients who are younger than 65 who have other health conditions that have had very poor outcomes as a result of COVID, be related to issues with regard to deprivation, or indeed other health conditions, especially such as diabetes, or indeed ischemic heart disease, or patients who have a body mass index of greater than 35. Also, we know that certain population groups have been disproportionately affected adversely by COVID. So in addition to those patients automatically offered acceptance to the ward, we know for patients under 65 in certain health groups, they need to be clinically assessed as to whether they would also meet the criteria for admission to the ward. I know that's quite complex to get your head around. It was much simpler before, when anybody over the age of 18 could be accepted. But understandably, with the increasing numbers, we do have to make sure that we focus on those patients that get the greatest benefit from the monitoring. If you can move on to the next slide, Scott, please. Thank you, that's lovely. I know that's quite a busy slide, so sorry, folks, I'll try and talk you through it. At the moment, there are many referral sources into the virtual ward. GP surgeries are receiving the positive test results into surgeries, and so your GP can refer you onto it. Patients who are COVID positive and who are unwell present at the GP hot clinics or primary care access clinics, and they can refer you in as well. If a patient presents unwell to the out of hours doctors, again, they can refer you straight into the virtual ward. Sorry, NEAS stands for North East Ambulance Service, and the paramedics, if they identify somebody at home who's COVID positive that they feel would benefit from the monitoring, they can also refer them in. Secondary care colleagues working in the emergency department or in front of house in the admissions unit, they can refer a patient if they are well enough to go home after assessment rather than being admitted. And also at the end of the pathway, if a patient is admitted with COVID and is well enough to be discharged, but isn't through that critical 14-day period when we like to keep an eye on people, they're able to be referred for step-down care and actually have monitoring after their discharge as well. We have a traffic light system as to who needs to be monitored and what level of scrutiny they need. The virtual ward uses a digital technology, an app, to help patients submit their reading. Now, I'm sorry, I'm not into apps, although I suppose I'm supposed to be at my age, but I'm not good with apps. And so for people that aren't good with an app or don't have the technology to be able to use an app, they can actually be contacted directly by phone by the people running the monitoring service, who will actually enter the data onto the app themselves. But for those people who are more savvy, they're able to enter their data twice a day after putting the oximeter on the finger, so that we know how they are doing from a pulse and oxygen point of view. They also enter some data about how their symptoms are, or what's changing. And if things are green, that if their oxygen is lovely and they are not any more unwell in themselves, then they can self-monitor. They remain at home in their own home, and they don't require any contact with the service. If they don't submit a reading, then the service do get in touch with them to make sure that, yes, it's just that they haven't got around to doing it, rather than that they're poorly or unwell. There's an amber category in the middle where, yeah, the symptoms have either changed and give cause for concern with the way it flags up on the automatic app, or indeed from what the patient says to the remote monitoring service when they contact them by phone. And that when the system notes when you put your reading in, if you enter a reading outside the twice a day requirement that flags it as a concern, then the app automatically flags up what you need to do. So if your saturation in the oxygen meter has gone down without it getting into the red zone, then it triggers you automatically, and a little message flashes up on your phone as to what you need to do. If you don't have access to the app, then when you call into the remote monitoring service with that data, then they will also inform you of that. And there's a lovely patient information leaflet for anyone who isn't savvy with the app to know exactly what they need to do if they enter the amber zone, either from their symptoms point of view or indeed from their oxygen point of view. If a patient is more poorly and they are having severe difficulty with their breathing, or they're unable to complete sentences, or their oxygen saturation drops to 92% or less, a red flag triggers up on the app, and they get an automatic phone call from the service, if they're having any contact with the service directly, to say that you need to phone 999 for an emergency assessment in hospital. It's quite a lot on there. The patients who have been through the process tell me, yes, it's really, really easy to do. The staff are really supportive when they phone it when they need to, and the app does provide an automatic trigger. So even though the service is not run 24 hours a day, by entering the data into the app, even if you entered it at 3 in the morning, that app would still tell you automatically what you needed to do should you need to take additional action, so that you know how to keep yourself safe. And that complements the patient information leaflets that we have got in 9 different languages, and we've got an easy read version as well. Once you've completed your 14 days of monitoring, or up to 14 days, because we know that if you're going to deteriorate with a silent hypoxia, it tends to be within the first 14 days of diagnosis. Then once you've completed that time, you can be discharged from the ward. Now, it is true that, yes, some patients do have ongoing health needs that are identified, and they will have their care passed to the care of their GP, because all this time through the process, if they've been unwell with anything else other than their COVID symptoms, their GP has had full responsibility for them. So yes, any ongoing symptoms will pass on to the GP. We have had patients from the ward who have had to be admitted and had further assessment. I am pleased to say that we thankfully up to this point we've had no patients that have passed away, and we have managed to satisfactorily intervene. And across the country, the mortality rates in patients monitored on the virtual wards has actually been much lower than patients who haven't been monitored, which, you know, is a big positive. If we can go on to the next slide, please, Scott. Thank you. So as you mentioned, there's lots of different referral sources, and I'm sorry that's really hard and small for you to see. I do beg your pardon. It just captures that we're covering the Tees Valley, and yes, understandably, some of the larger areas who've had higher numbers of COVID positive patients have had more patients who were referred through, but we're just under 300 at the moment. In fact, actually, to be fair, as of today, we probably are over the 300 mark now, and we've actually got 44 patients on the ward today. It is true that when we have a big batch coming through at once, the numbers do go up, and we have been up to 50 at some points, and we're currently at 44 patients on the ward as it stands today. And it's obviously a regular throughput with patients moving through. If that's so tiny, sorry, if I move on to the next slide, Scott, because people might be struggling to read that one, sorry. This is just a patient story. Happens to be a patient from Billingham, but it could apply. That sort of really just emphasises the benefits that the service has given to patients. Some of the reassurance that they get, the ease of being able to use the app, or be supported to use the app, whichever way is going to work best for individuals. And if we can go on to the next one as well, if that's okay, conscious of time, Chair, sorry. Staff, understandably, as you've mentioned already, it's so important that we support our staff at the moment because everyone is working really hard and very differently. So it was nice to be able to include this. A member of our nursing team who's working with the remote monitoring service, who knows what it was like before the monitoring services were in place and brought about. So it is good to know that, yes, she gets a feeling of self-worth by being able to provide this service to patients, but also recognising that we have learned about some of the things that we can do differently to try and have more in our armoury, you know, to protect ourselves and our population against COVID. If we can go on to the next one, please, if that's okay, Scott. Thank you. Yeah, understandably, when we've asked for patient feedback, the patient feedback overwhelmingly has been how much they value the monitoring service that has been in place. Other areas around the country have expressed some concern. Some patients have actually found it creates anxiety because they're having to do the monitoring. But our experience actually has been that patients have really valued the service. There have been some patients who actually discharged themselves from the ward because they weren't happy to continue doing the monitoring. But actually, to be fair, that was because they were really well and had significantly improved. Now, sadly, we know that with the change criteria, because they are going to be the patients that are more likely, sadly, to deteriorate, then yes, we're expecting the cooperation with submission of the results to go up, and actually, therefore, the benefits potentially are going to be greater, and make sure that it is something that we can do to hopefully reduce the mortality and morbidity that otherwise occurs with COVID. And I think that's the last slide. If you can go to the last one, Scott, because I think it just says questions for the next one. Thank you.
I don't have any, so I'll open it up to the rest of the committee, please. Councillor, sorry, David, Councillor Coop, sorry. Yes, Councillor Coop, off you go.
Yes, thank you, Chair. Being someone who's been very interested in tech over the years, would you see this as a possible future for the health service? I know not everybody can afford one of the iWatches and things like that, but having said that, if this sort of thing would help, certainly I'm thinking of the older population, that they'd be able to use something like this with the advancement of computer and technology and the advances of 5G and the Internet of Things. This certainly could help bring around some revolution in healthcare, because if someone has an ongoing problem, once we get away from COVID, that they would be able to use something like this, and it would be a benefit to the health service as well, rather than having people going in and out of hospital.
Yes.
You can say, right, you're okay at the moment, or in the future, okay, you should perhaps come into hospital.
Absolutely, no, I entirely agree. And there's a whole programme called NHS at Home that is looking at how you can monitor patients differently in their own home, and patient empowered monitoring, because, you know, we have some patients who are expert patients who are really, really knowledgeable about their condition. And so, yes, giving them the tools that helps them to more safely remain at home has to be in their best interest, but also for the rest of the health service as well. So, and it is recognised that the benefits of the learning that we're going to get out from these approaches and the bits of kit that are left over, they won't be going to waste, because we've already got all sorts of uses that potentially they will enhance patient care. So definitely, I would agree. It is a way forward for the future, having patients monitoring themselves safely at home with just that bit of backup when they're able to do so. Absolutely.
Can I ask you something, please? Sorry, I thought you'd finished, David. Sorry, off you go.
Just one. I think we're a few years off the hologram doctor out of Star Trek, but I do believe that this sort of thing could be very useful, and that would actually, you'd actually press a button and you'd bring sort of some more automatic AI healthcare up, and I think that's where the future is. That would help the health service enormously. Thank you, Chair.
John, can I ask you? You mentioned NHS at Home.
Yeah.
Do you have any leaflets at all that you could send to us councillors that we can pass on to appropriate residents, please?
No, it's more a learning network at the moment about projects and schemes that are going to be coming. So I'm so sorry, it's not suitable from a leaflet perspective, but I can certainly dig out and have a look at what materials there are that could give you more awareness of the learning programmes that are going on at the moment. The Academic Health Science Network are working with the NHS very closely to develop a variety of, call them telemedicine schemes, that look at how you can have patients monitoring themselves more closely. One of the other elements that sort of is an expansion of what we do with the virtual ward is our local care homes have been involved with the Academic Health Science Network, looking at something called News 2 assessment, which is a way of assessing how poorly somebody is and whether they are deteriorating more quickly. That really helps paramedics know whether that patient from a care home setting, where the staff aren't medically qualified, may need a more rapid response. And that is something that is an extension of this, which is proven to be very effective.
Okay, thank you very much. Any more questions? No. I think that's the finish of item 5. You're allowed to go home if you want to. Sorry, you're allowed to leave us if you want to. You're very welcome to stay first of the meeting, but obviously I'm sure you've got more important and more pressing things to go to. So thank you very much for your help. It's a great deal of excellent information that we didn't know, and we can pass on to residents, and certainly they can pass on to social media, because there's an awful lot of false information floating around on social media. So we are now in a position to correct that. Thank you very much indeed. Item number 6. I think is Lisa here? No, she is. Hello, Lisa. Can I just ask you a question before we begin? Are you in relation to a David Busworth, the late David Busworth from Gisborough?
He was my father-in-law.
I worked with him at the Evening Gazette, and he was a delightful man.
Yes.
I thought you might be, with it being such an unusual name.
Yeah, he's my husband's father, and unfortunately Jacqueline Busworth passed away a couple of years ago as well.
Oh, I didn't know that. Which son did you, another two, which one did you marry?
Well, again, unfortunately, the Graham was passed away in a car accident when he was 17, so I married just Neil.
Graham was the naughty boy.
Yeah, well, I don't know. Neil's not done so bad in the last
He was always coming to work telling us all the terrible things that Graham got into. Anyway, nice to meet you.
Yes, nice
and off you go. Off you go.
Hi, everybody. I hope that you've had a chance to read through all of the information that I have shared with you. And just to a little bit more interesting, because I know these days we're always sort of just sat looking at screens, listening to people talk. So I just thought we'd done a little animaker video just to explain a little bit in more depth about what Health Watch is, that I'd quite like to show you. So if you could bear with me.
Hello.
Right, can you see that? Yep.
Yes.
Okay. hopefully that was just a little bit more of an interesting way, just to give you a little bit of background on what Health Watch does. We did that to using a few focus groups where we knew that people might not have the confidence to sort of speak up about things. So I just thought I'd share that with you today, just to try and lighten things a little bit. You've all seen, as I've said, my paper, and as showed in the little animation there, the 3 ways that Health Watch collects information obviously has changed ever so slightly during recent times. So we are really busy and with our information and signposting service at the moment. As you can imagine, lots of people are struggling to find how to access different health and care services. And we might not have all of the answers straight away, but we are connected well enough to be able to find that information out for them. It also gives us one option of gathering community intelligence for our work that informs the direction that we will go in. Obviously, our focus community consultations and attending events are somewhat scuppered at the moment. So you will see in the paper we are addressing this by recruiting what we refer to as community champions. And I'll go into that a little bit further on in my presentation today. And unfortunately, the enter and view activities aren't an option for us at the moment, but we are currently trying to think of ways that we can get over and around this by maybe doing some virtual options in the future. But at the moment, we're collecting intelligence by the first 2 on the list that I've provided. A little bit further on page 2 of the paper that I shared, you will see that we have produced a number of reports this year based on our work plan priorities and also intelligence that we get. We've recently produced a report on the experiences of lockdown across South Tees, which again, I've shared some insights and intelligence with you. But also attached to that, as part of that survey, we asked people to recognise or to highlight to us where there had been some great examples of service provision. And it was that big, the list that we had. I think it was about nearly 300 thanks that we received. We had to do that in a separate document just so it didn't make the report too big. So again, you'll have seen the link that I've provided to you, which is just a lovely positive read at the moment, because everything seems to be a bit doom and gloom and a bit negative in terms of what people are experiencing. So it's just nice for us to shine a light on those services that went above and beyond to help the local community during our first lockdown period. As you will see, we were previously managed by MVDA, Middlesbrough Voluntary Development Agency, and RCVDA, Redcar and Cleveland Voluntary Development Agency. And earlier this year, the contract to manage Health Watch went out to tender, of which PCP, which is Pioneering Care Partnership, won. So we've gone through a very strange TUPE process, myself and the team, from our kitchens. So one day we got up and we were working for one organisation, the next day we got up, we were working for another. So as you can imagine, trying to manage and supporting local communities whilst navigating our way through a brand new organisation hasn't been easy, but I do feel that we haven't dropped any balls at the moment, so hopefully we can continue to do that. Right at the beginning of lockdown, we thought it was really important to gather experiences from local communities of their health and social care, trying to access or to continue medication or support that they were getting. So again, I've provided a link to the full report, but I've just highlighted in the infographic on page 3 some of the sort of top responses that we got. And I've also on page 4 provided a summary of key themes. People were appreciative of how efficient services had been in comparison to what they had experienced before COVID-19, but that was in respect of they were now able to get telephone calls and virtual appointments, which actually saved them the travel or the cost of travel and parking, etc., to see the doctor or to receive any sort of support in terms of health and care services. So quite a lot of people actually quite liked that option. All the way through, staff were described as friendly, helpful and supportive. People seemed to be happy with the safety measures that they had in place. Video calls were seen as an efficient, safe and reassuring way to access care during the lockdown period. However, there were certain issues and areas for learning that, again, I've mentioned that on page 14 of our experiences of lockdown. We have done some good practice and recommendations for those who are offering virtual services, as well as those who are receiving them as well. All of our information, community intelligence and reports are shared very widely. Health and Wellbeing Exec, CCG, CQC, Celtes Hospitals NHS Foundation Trust and service deliverers themselves, as well as directors of health and social care, to name but a few. We also acknowledge that in the report and in our completion of surveys that our research was somewhat limited just by the demographic of people who had completed the survey, but that was not to reduce the importance of what they were telling us. But in order to address this, we have decided to build on 3 areas of the analysis, which again I've highlighted here, and drill down a little bit further to get some more information in relation to experiences of accessing GPs, experiences of the impact and new treatments being cancelled or postponed, and the big thing at the moment that's on everybody's agenda is mental health and access to those support services. So we decided, how can we still have access and reach to our communities? And we're not saying by any means that this is a way of addressing every community, but it was a start. We are obviously aware that quite a lot of communities are excluded digitally, but at the time we only have that as an option, and we are looking now into other potential opportunities that we can try and reach out to those communities who are digitally excluded. So what we did was we tried to identify key individuals who represent seldom heard groups. So it was either those who were quite active in the community, just members of the public, or it was those who had a professional capacity linked to services who were still offering face-to-face or virtual support in the community. As you can see, we've made a good start and have so far recruited 14 champions just in the last few weeks. And again, I've given a list here of areas that they represent, so we can start to get some feedback from the groups that we weren't initially connected to. And I've also had some discussion with a representative from the local authority about how we can get the word out and better engage with BAME communities in our 2 local authority areas. So what we want to do is, with those 3 areas that we want to drill down further in, experiences of access to GPs, the impact of ongoing and new treatments being cancelled, and the mental health, is that each of our community champion will promote and encourage the completion of and support the completion with those specific communities of interest. So hopefully by the end of that process, we will have a series of mini reports that will all be asking the same questions, but would have a focus on that specific demographic. So, for example, we'd have a mini report on those issues from LGBTQ communities, or from young people, or from those who have hearing loss, who are visually impaired. And we will have a look at those specific reports, but also tie some generic themes as well. We share, as I say, we're part of the Health and Wellbeing Recovery Group that is active in Middlesbrough at the moment, and we've recently had a conversation about how Health Watch could be the provider of that qualitative data to enhance and inform some of the quantitative data as well that we're looking at over specific topic areas and focus work plan areas. I also included in Appendix 1 just some examples of some intelligence that we just started to gather through our Community Champions role. There's lots and lots of other things that we're involved in at the moment, but before I moved on to the South Tees neurodevelopmental pathway and our work in that, I just wondered if there was any questions based on our lockdown report and some of the intelligence that we're getting.
I have a question, Lisa.
Yeah.
Sorry, David, was David before me?
I
Were you
didn't
before
notice.
me, David, or are you going to let me go first? Okay. Yes, you gave me the impression that it wasn't easy to contact the people that you needed to contact. Yes? Would it be possible to ask councillors for their input? Because I'm sure we all know people on our ward that would fall into that category.
Absolutely, Joan. And it's interesting that you should say that, because right at the beginning of lockdown, we sent an email to every councillor and every local MP just raising awareness of Health Watch South Tees, offering to be a link between what they're hearing on the ground of their constituents and sharing that information with us. But we only had one response. So maybe that's something that sort of from attending here today that we could maybe build on. And you'll notice at the end of the paper, I have suggested of what sort of the people in attendance here today, Chair, could maybe do to support this work. And one of them is either become a Health Watch South Tees champion themselves, or if they could identify somebody who's quite active in their community. I'd be more
I'm sure some of the people on the panel will, certainly.
That would be great.
Okay, David, you wanted to come in? David?
Yes, thank you, Chair.
Yeah.
Can you hear me?
Yes.
Yes.
Yeah, I am. Hello. Yeah, can you hear me? Right. What I was interested in the report, can you hear me? Or I'm still having IT difficulties.
Yes. Yes.
Hello.
Yeah.
What I was interested in is how you address the older people that don't have access to IT.
Yeah, and that's where we were reliant on our champions. One of our champions you'll see is connected to Age UK. We've also just recruited somebody from Age UK on our partnership board who oversees our work. And we've also just recruited another champion that I haven't included here that links to Aging Better Middlesbrough as well.
Is that okay, David?
Yes, thank you. I'm still Aging Better to me again, but no, I just wondered, because there are a lot of people who miss out. They don't have relatives unless they have IT, etc. And there'll be a small group of people that you're just going to miss out, and it's addressing the problems with them, I think, is most important.
Absolutely,
yes.
You're right, David. We've just received through our work with our champions a report that's just been done by Age UK, looking again on the impact of COVID on those age demographics, which again, if you're interested in, I can maybe share with Caroline for her to disseminate. And there's some real quite sad, but in really useful intelligence in that report. And they're sort of, that's the type of sort of connection that we have that feeds into what we're doing. But you're right, and we don't really know what that answer is totally at the moment, when obviously the government guidelines are restricting us in some ways to go out and do some of that direct work where we would normally have done that. But that's why we're trying to build up that community champion role and numbers of people, so we can ensure that those groups aren't missed out.
Okay, David.
Yes, thank you. I do believe I do believe that there'll be at least a level of population who are really missing out here. So it is important. Thank you.
It is. Thank you.
Are you finished now, Lisa?
Yes, well, I was going to just very quickly, I don't know, I know that Caroline informed me that you have previously been informed or aware of some work on the neurodevelopmental pathway, and I don't know if any of you know what that is. But just very, very quickly, previously there's been an autistic pathway where children and young people can be referred to for a diagnosis. And next year that will change, and it will be called the neurodevelopmental pathway, which will encompass a lot more neuro issues and disabilities, and in a much wider context than just autism and associated disabilities with that. And what they are proposing is that any child, regardless of need or a diagnosis, will be referred onto this pathway and offered what they are calling a bubble of support. And the families and the child can continue with that bubble of support. Yes, it will be flexible and would need amending as the child changes and develops to make sure it continually meets need. But they have the option to go down the diagnosis route through that pathway, or they can just continue with that bubble of support if need be. We have been instrumental in carrying out some consultation with parents and carers who have children who have SEND, so special educational needs and disabilities, to find out what's working in terms of support that they are receiving at the moment, what isn't, what lessons we can learn and where the gaps are, and that will inform the commissioning of the services to offer that bubble of support. We've recently had 91 parents who have completed the survey, and we've held 5 focus groups that 15 people took part in, and they represented Middlesbrough Parents for Change, Parent and Carer Wellbeing Group, Chasing Rainbows, Redcar Cleveland Parent Carer Forum Group, the Autism Group, and as well as some individuals. And again, I've put a link on here to a lovely video of one of the parent carers in one of those consultation sessions who just started to speak freely about her experiences of having an autistic son. And she refers to it that we don't have an autistic child, we are an autistic family by proxy. So there's some lovely information there, just what it's like living with a child with autism. If you want to have a little look at the link, and our final report will be due for circulation on that at the end of this month.
Thank you, Lisa. That's very assuring, because one of the things I often hear is that parents who believe their children are autistic are having to jump through hoops to get their child diagnosed. Oh, there's a long waiting list, or they simply are frustrated at the length of time. So it's very good news. Thank you.
Absolutely. And a lot of parents, because when they first suggested this pathway, they were suggesting that only educational staff and health staff could refer, and they were going to take away the self-referral element of it. We shared our concerns about that, because a lot of children can sort of keep it together in a school setting, and it's only because they've been trying to keep it together all day that when they get home, that's when the problem starts. So they have very much taken that on board and are looking at alternative routes for the potential of self-referral.
Yes, and let's not forget, parents know their children better than anyone else.
Yeah.
Like you said, children can put on the front when they're away from home, but it's only when you see them and they're in their own natural surroundings that you see the real child. So
autistic females in particular are very good at hiding it.
Thank you. Any questions from anyone? Councillor Higgins, yes, would you like to come in?
Thank you, Chair. It's some questions that Councillor Halawi asked me to find out the answers. First of all, how many children will be able to be seen at the same time? How many, because of the staffing?
Okay, at the moment, I don't have those figures. It's definitely something that I can find out for you, because we haven't been involved in the development of the pathway. We've just been involved in the development of the bubble of support on the pathway. But that's something that I can very easily find out for you.
Thank you. And I also looked at the bubble.
Yeah.
And it looks as if it's going to take a long time before the person or the persons get to the end. How long do they think it's going to take before they accept that that child or that adult needs help?
Again, it is my understanding, but I can get some clarifying information from you, for you. It is my understanding that as soon as the child is referred onto the pathway, that bubble of support will happen immediately, whilst for their initial needs, whilst there are sort of assessments and things going on in the background to ensure that that child is supported fully.
Thank you. It's just that I totally agree with Councillor McTeague about when you get talking to parents who have, you know, children with these problems, they are very much, you know, they don't seem as if they get the help as quick as they need. So
Yeah.
I agree with Councillor McTeague there. We need to get this sorted for the children. Every group I'm on where it deals with children, the earlier any problems are recognised, the better it is for the child.
Yes,
So
I totally agree with you.
Yeah. Thank you very much.
No, thank you. And some of the stories, some of the stories that we heard through our consultation with parents, it's really soul destroying to hear about what they had to go through in order to get what they needed for their child.
Yeah. Any more questions? No. Well, thank you, Lisa.
Okay, you're very welcome.
Very informative and nice to meet you personally.
Yes,
so
and you. Yeah.
Okay.
If anyone would like to connect with us around that community champion role, any ways that we can help support, any information sharing for your constituents, please get in touch with Caroline and she will forward your details or my details, vice versa, and I'll get those answers for you.
Thank you, Lisa.
Thank you.
Can we now go on to item number 7? The overview and scrutiny report, which I will be as brief as possible. The OSB meeting met last Thursday, and we considered the following items. Firstly, the Executive Forward Work Programme. Secondly, the Council's response to COVID-19. The Executive Member update was given by Councillor High as lead member for Social Services, and the Chair also asked him if he would give some information on drugs, potholes, etc., which we persuaded him to do. A report on the proposed amendment to the OSB membership was discussed. Has to be referred to the full council, next full council meeting. The final report on the adult social care and final report on adult social care and the physical activity for older people was discussed or presented. The final report on children and young people's learning security panel was presented. The final report on the economic development scrutiny panel was presented with particular reference to Teesside Crematorium. And finally, the scrutiny chairs presented their monthly updates. Does anybody have any questions? No. Okay, fine. Now where are we? Item number 8. If anybody has any urgent items which they want considering. No. Okay, well, as far as I'm concerned, that's the end of the meeting, apart from to tell you all that the next meeting is, my specs aren't working, the 8th of December at 4 o'clock. I wish thank you all again for coming, especially our visitors. I wish you a pleasant evening, stay safe, and good night to you all.
Thank you, Chair.
Thank you.
Thank you, Chair. Thank you.
You're welcome.
Thank you.
Bye, everybody.